Speaker on
That's
over here.
The other, and if, you may not need that.
Okay.
People in the back can say if you need that.
Do you mind handing me that? Wonderful. Okay. So for an overview of what I will be covering in the next 50 minutes or so, I promised Pat that I would keep it to around 50 minutes. I'm going to start with some general background information on food insecurity, including its prevalence, definition of food insecurity, and a conceptual framework for how it's linked with the HIV/AIDS epidemic. I will then spend a lot of time talking about why food insecurity, all the different ways that food insecurity is bad for your health, mostly focusing on HIV, but also bringing in some other outcomes. I'll then turn to the mechanisms and pathways for how food insecurity is worsening health, looking specifically at nutritional, mental health, and behavioral pathways. And then we'll spend quite a bit of time talking about intervention studies. So while there's several definitions out there of food insecurity, a definition I really like is the Food and Agricultural Organization's definition of food security, which is access by all people at all times to enough food for an active, healthy life. And food insecurity, in turn, is the limited or uncertain availability of nutritionally adequate, safe foods, or the inability to acquire what's thought to be personally acceptable foods in socially acceptable ways. So there's 4 essential components of food insecurity. Many people just think of insufficient quantity of food as, being the definition, but food insecurity is broader and also includes insufficient quality of food, feelings of deprivation and restricted choice and anxiety about the amounts and types of foods available, and finally, being unable to procure foods in socially acceptable ways, so without having to beg, rely on charity, or steal. So this figure shows the overlap between food insecurity, economic insecurity or poverty, and undernutrition and overnutrition. And the main point I want to make here is there's incomplete overlap between these things. So certainly food insecurity contributes both to malnutrition and is a big contributor to the growing obesity epidemic in this country and elsewhere. But you do see the negative health impacts of food insecurity occurring long before individuals are frankly hungry or malnourished, and I'll explain why later in the talk. You also find undernourished people who are not food insecure if they're undernourished due to illness, an eating disorder, or another reason. You find overweight people with and without food insecurity and with and without economic insecurity. Now for the overlap between food insecurity and poverty, which food insecurity researchers are asked about a lot. You also see incomplete overlap between these constructs. So about half of individuals in the U.S. living under the federal poverty line are food insecure. And you also find worldwide individuals living in wealthier or relatively wealthier families who may be food insecure because of unequal household food allocation, because of drought, or some other reason. And I think most importantly, studies have consistently shown that the negative health impacts of food insecurity persist even after extensively adjusting for other measures of socioeconomic status. And for me, a reason I like to focus on food insecurity is that it's slightly, at least, more feasible target for intervention than addressing poverty more broadly. So how common is food insecurity? Well, food insecurity is still very common in the US, affecting 13% of all households. And you can see that the prevalence is higher among minority households as well as among poor households. And chances are it won't get any better in the near future. In fact, the Farm Bill Act is due to be renegotiated in 2018, and the Supplemental Nutrition Assistance Program, which is one of our most important safety net programs, is part of that. And unfortunately, our president is also a big fan of fast foods that may manifest politically in continuing subsidies for keeping the fast foods cheaper than healthier alternatives. So in terms of HIV and food insecurity, worldwide, these can be thought of as endemic issues. You can see that the regions of the world that have the highest prevalence of food insecurity, shown in the top map in the pink and red colors, strongly overlap with those regions that have the highest HIV prevalence, shown in the bottom map in the purple colors. And food insecurity is extremely common among HIV-infected individuals in resource-rich settings. So for instance, studies from across US and Canada show that about half of HIV-infected individuals in care are food insecure. And this includes some of the best resource settings for HIV in North America, like San Francisco, Vancouver, and others. And speaking at CUNY yesterday, Dennis mentioned that I need to add a New York data point, and I will do that in my next talk on this chart. So just to talk a little bit about the overlap between food insecurity and gender inequality. So food insecurity disproportionately impacts poor women worldwide, and you find that 60% of individuals worldwide are women and girls. This occurs in part because women prioritize feeding their family and their children over feeding themselves. And you also find that women are forced to leave work early to serve as caregivers, or work or schooling early, which prevents them from further investing in their own skills and education. And as a result of this, you see more female-headed compared to male-headed households being food insecure and living in poverty. And you also find that women within relationships are more food insecure than their male counterparts because of unequal household food allocation. In an analysis in Uganda led by Mark Seidner at Harvard, we also found that women with lower sexual relationship power had higher food insecurity and malnutrition than those with higher sexual relationship power. So food insecurity and gender inequality can also be thought of as endemic issues. And I'm going to be showing these maps a few times throughout the talk, and you can see that the same regions that have the highest prevalence of food insecurity, again shown in the top map, those same regions that have the highest prevalence of HIV, also have the highest gender inequality ratio, shown in the bottom map in the red colors. And so this ends up, as a result of this interplay between food insecurity and gender disempowerment, women often feel compelled to engage in risky sexual practices. Many years ago, when I was doing a study with Physicians for Human Rights in Botswana and Swaziland to try to understand what was perpetuating the HIV epidemics over there, in one of my first qualitative interviews, a woman says, well, it's obvious women are having sex because they're hungry. If you give them food, they would not need to have sex to eat. And another woman described her choices rather starkly. She said, either my children and I starve tomorrow, or I have sex with someone today and maybe get HIV and will then die 5 to 10 years later. So nobody should have to make these kind of choices. And as a result of these dynamics, women may feel compelled to stay in violent and abusive relationships. So here's a quote from one of our study participants in Uganda. They decide to stay with their husbands no matter how badly they're being treated, because their husbands are providing some food. So looking at this interplay quantitatively, there's now a lot of studies, this is only a handful of them, looking at food insecurity and risky sexual practices. And among women, there's been really quite consistent associations in many different settings. For example, in studies from our group in Botswana and Swaziland, Brazil and Nepal, and these are all population-based studies, food insecure women had higher odds of unprotected sex, sex exchange, and symptoms of sexually transmitted infections. And also in longitudinal studies from our group, as well as Kate Shannon in Vancouver, we've all found similar things about, with cohorts of both men and women. In fact, looking at NHANES data, population-based data across the US among men, Kartika Pilar led an analysis where we found that food insecure men had higher odds of HIV seropositivity, of herpes simplex 2 seropositivity, and self-reported gonorrhea, chlamydia, or genital warts. And you can see that the associations for most of these were even stronger among men who self-identified as being an MSM. So let me turn to what we know about food insecurity and health for HIV and chronic disease. Because this is an HIV talk, I'm mainly focusing on the HIV angle, but I'm happy to discuss more about chronic disease in the discussion. So here is a conceptual framework we developed to understand the bidirectional links between food insecurity and HIV, and it also applies to chronic disease. So food insecurity and HIV/AIDS can be thought to be linked in a vicious cycle. Each enhances the severity of the other condition and enhances acquisition risk. So food insecurity directly contributes to poor nutritional status, poor mental health, and poor adherence to treatment and care recommendations. And through these pathways, that could increase risk of HIV acquisition and also worsen health outcomes when they're infected. This then drives utilization of expensive healthcare services like hospitalizations and ED visits, which can drive up healthcare costs. And then as a result of the increasing disability as well as out-of-pocket health expenses, this then drives families and individuals further into poverty and unemployment, which then perpetuates a vicious cycle between food insecurity and poor health. And I'll use this model as a way to talk through findings at several points in the talk. So food insecurity and HIV can actually negatively impact individuals along the entire cascade of care. I've already shown you data that food insecure individuals have higher odds of being HIV infected. Food insecure individuals have 2 times the odds of missing their clinic visits, have 2.7 times the odds of ART non-adherence, 70% higher odds of failing their HIV therapy, have 45% higher odds of progression to AIDS, and are even 2 times more likely to die compared to food secure individuals. And I'll just show you some of these data. Here are some longitudinal data. There's again, this is just a handful of the longitudinal studies looking at food insecurity and HIV treatment outcomes. So we conducted, along with David Bangsberg, parallel longitudinal studies, one in Uganda, one in San Francisco over the same time frame, and found that food insecurity in both cohorts was associated with higher odds of unsuppressed viral load and lower CD4 cell counts in longitudinal analysis. In a study in Boston by McMahon et al., they found that individuals who were food insecure at baseline had lower gains in their CD4 cell counts over time compared to individuals who were food secure. And then Dr. Feldman from New York City, who is, I think, here, there we go, also conducted a study among over 2,000 HIV-infected clients as part of a food and nutrition program, and found that food insecurity predicted higher odds of unsuppressed viral load. And the results were not significant for CD4 count. So in terms of studies linking food insecurity with mortality, we did 2 studies in British Columbia, and I'll just mention the more recent one by Aranka Anima, where we found that individuals who were food insecure at baseline were about twice as likely to die over the 13-year follow-up compared to individuals who were food secure. This has important implications not only for morbidity and mortality, but also for healthcare costs. In a study in San Francisco, we found that food insecure individuals or severely food insecure individuals had 2 times the odds of being hospitalized and 71% higher odds of ER visits in adjusted analysis. And we also found similar associations with hospitalizations in Uganda. And this really does suggest that not addressing food insecurity is costly for the healthcare system over the long run. And I didn't bring in the data here, but there was also a study from Ontario where among over 67,000 individuals, where the authors found that healthcare costs were about 1.8 times higher among severely food insecure individuals compared to food secure individuals. So food insecurity outside of HIV is linked with a host of chronic diseases, and these are population-based studies in the US have found that food insecure individuals have 2 times higher odds of having diabetes, 20% higher odds of having hypertension, 30% higher odds of having hyperlipidemia or high cholesterol, over 3 times the odds of osteoporosis, and 46% higher odds of chronic kidney disease. And I'm just starting a mentoring mid-career award in the WIHS cohort looking specifically at food insecurity and aging outcomes. And there's been some cross-sectional data also suggesting that food insecurity's increasing prevalence of cognitive decline in aging populations, as well as frailty and other negative outcomes. So now let me turn to these pathways for which food insecurity is exerting its negative impacts. So first of all, there's been quite a bit of data showing that food insecurity is associated with poor nutritional status. It contributes to micronutrient and macronutrient deficiencies, to poor diet quality, and also, as I mentioned, to the obesity epidemic. And this is an important pathway towards worse HIV/AIDS and chronic disease health. As an example of this, in a study actually in the WISE cohort in the Bronx, and this was an analysis led by Nicole Seritin, and Kathy Anastos was also a strong contributor. we found that food insecure, HIV-infected, and at-risk women had over 2 times the odds of being obese compared to women who were food secure. The mental health pathway is perhaps one of the most important pathways through which food insecurity is exerting its negative impacts. Many studies show that food insecurity is associated with depression, anxiety disorders, drug and alcohol use disorders, and poor overall mental health status. And these are important pathways towards worse HIV/AIDS and chronic disease health. Yes?
Can you explain the stigma part?
Yes. So we have found in Uganda and now again in the Women's Interagency HIV study that there is a strong bidirectional link between food insecurity and HIV stigma. The direction of causality is complicated, but at least antecedent food insecurity is predicting later stigma. We also know from our qualitative work that there is a lot of stigma around food insecurity, and I think that that goes into the category of the work on intersectional stigma, where people who experience multiple different kinds of stigma, have an exacerbation of, or have worse outcomes than people with just in one stigmatized group. So in the Women's Interagency HIV study, for instance, Emily Toothill, who's a postdoctoral fellow in our team, found that food insecure women had 5 times the odds of screening positive for depression. They also had higher odds of a poor mental health status. And importantly, women who were food insecure at multiple time points really were at highest risk compared to those with short-term food insecurity. In the WIHS cohort, we also found very strong associations that we've presented recently at a conference with food insecurity and post-traumatic stress disorder symptoms and generalized anxiety disorder symptoms. Oh, and one more thing that I'm not presenting the data here, but there's also very strong links between food insecurity and multiple categories of substance abuse as well in the WIHS. So food insecurity is an important driver of poor health behaviors like medication non-adherence, treatment interruptions, and missed clinic visits. For example, in a study in the US, again, a population-based study using NHIS data among over 67,000 adults, severely food insecure individuals had 3.7 times the odds of skipping their medication doses and 4 times the odds of delaying their medication refills compared to individuals who are food secure. Looking specifically at HIV and now in the WIHS, Kartika Pilar led an analysis where we found very strong associations longitudinally with food insecurity and missed clinic visits. And in this analysis, we stratified by those on antiretroviral therapy and not on antiretroviral therapy. And you can see that the associations were even stronger for those not on antiretroviral therapy. So in looking at the associations between food insecurity and ART adherence in the WIHS, we actually looked at this adherence in 4 categories. So the referent category is 100% or perfect adherence, and we looked at mild non-adherence, so 95 to 99% adherence, moderate non-adherence, 75 to 94%, and severe non-adherence, which was less than 75%. And what you can actually see is a dose-response relationship going in multiple directions. So you can see that as the degree of food insecurity worsens, there's more non-adherence, and also stronger associations as you move to the right towards severe non-adherence, such that those with very low food security had about 11 times the odds of severe non-adherence compared to those who were food secure. We also find in the same models that people with previous food insecurity actually had independent relationships with adherence outcomes, even when adjusting for current food security, and those who were persistently food insecure at multiple time points had the worst adherence. So in the WIHS, my R01 actually was specifically aiming to tease apart these nutritional, mental health, and behavioral pathways through which food insecurity negatively impacted HIV treatment outcomes and cardiovascular risk outcomes. Because this talk is focused on cardiovascular risk, I'm mainly going to focus, because this talk is focused on HIV, I'm mainly going to be focused on HIV treatment outcomes, so I won't present the cardiovascular risk outcomes. But I just wanted to mention that we also in exploratory aim, had hypothesized that food insecurity may be associated with increased inflammation, gut microbial translocation and T cell activation, and that may be another mechanism through which food insecurity negatively impacted health. So now, in looking at that aim looking at HIV treatment outcomes, we looked at 4 different HIV treatment outcomes. So the first outcome is a TOBIT model, looking at viral load, which combines actually whether the person is suppressed or not suppressed, and then the magnitude of the suppression. The second outcome is looking at whether they're suppressed or non-suppressed as a dichotomous variable. Then we look at CD4 cell counts and physical health status. You can see, and these are all adjusted analyses, a dose-response relationship between food insecurity and both viral load outcomes. You can see that the most severe category of food insecurity, which is referred to as very low food security, was associated with decreased CD4 cell counts. And then dose-response relationship with all categories of food insecurity, predicting worse physical health status. Then we looked specifically at these pathways, and this is a little complicated, so I will walk you through what we did. So first of all, we chose a candidate mediators along the nutritional, mental health, and behavioral pathway, and chose the strongest mediator in each pathway for each outcome. And so for the nutritional pathway, body mass index was the strongest mediator for the viral load models, and fruit and vegetable intake was the strongest nutritional mediator for the CD4 cell count models and the physical health status models. And then for the mental health pathway, depression was the strongest mediator for all the models, and adherence was the most important behavioral mediator. And what you can see here is that different mediators played a different role depending on the outcome. So looking at the viral load models, whether we look at log viral load or viral non-suppression, the behavioral pathway, so non-adherence, accounted for about 30% of the total effect, with the nutritional pathway accounting for less than 3% of the total effect. And interestingly, based on our qualitative work, people had actually described a depression driven by food insecurity contributing to non-adherence. So we also tested serial mediation, and from food insecurity to depression to ART non-adherence to viral non-suppression, and that pathway, did exist. So some of the behavioral pathway is being also mediated via depression. For CD4 cell count models, you can see about 15% of the total effect accounted for by the behavioral pathway and about 15% by depression. And for physical health status, this is mostly driven by depression, accounting for 60% of the total effect. Finally, just looking at our exploratory aim and whether food insecurity is driving inflammation, we haven't yet looked at our immune activation data. In an analysis led by one of our fellows, Anna Leddy, that's going to be presented at CROI, we did find that women who were food insecure had higher levels of both IL-6 and TNFR1, which are important inflammatory mediators associated with higher risk of mortality, of chronic disease risk. And we wanted to explore whether this was all driven by poor HIV control. So was this all mediated by poor viral control? So we adjusted for time-updated viral load as well as CD4 cell counts, and the effects still persist. And then to really fully account for that association, we actually even did a restricted analysis looking only at those people with CD4 counts greater than 500 and unsuppressed viral load, and we still found these same associations, suggesting that food insecurity is acting independent of viral control. So before I turn to interventions, I just want to summarize what we know about food insecurity, HIV outcomes, and mechanisms. So we've seen that food insecurity is associated with worse virologic outcomes, worse immunologic responses, increased hospitalization, higher mortality, and higher risk of chronic disease. The mechanisms include worse ART adherence, missed clinic visits, increased undernutrition and overnutrition, worse mental health, and at least in that one study, possibly increased inflammation. Excuse me. So,
before you get to, just explain how actually completely food insecurity is assessed.
Yes. So it is, there's several scales in the data. There's several validated scales. The one we used in the WIHS cohort was a 16-item scale validated by, or sorry, an 18-item scale validated, yes, self-report by the U.S. Department of Agriculture. And then in Africa, there was a different one that we used that was a 10-item scale that's been more validated in the African context. So this was, very depressing information, all of the ways that food insecurity is very bad for you. So I thought I would end at a more uplifting note to think about what we can actually do about it. So there's a critical need for intervention research to understand, first of all, whether improving food insecurity will improve health outcomes, and if so, which health outcomes will be most affected. If you're using some form of targeted food supplementation for, how long do we continue food support programs for to achieve optimal outcomes? Who do we target with these food security programs? And which various options for improving food insecurity will be most effective, cost-effective, and sustainable? And we anticipate that this will vary with country and context. So there's many possible interventions in place for addressing food insecurity. Targeted food supplementation in clinics, food banks, and war meal delivery programs, to food stamps and vouchers like the Supplemental Nutrition Assistance Program, to more upstream interventions like cash transfers for food and even livelihood and vocational training programs. So going back to the model that I showed you earlier, the evidence is definitely not quite as robust in terms of intervention studies thus far, but the evidence to date does suggest that food security interventions can reverse many of the negative health impacts that I've just reviewed and could lead to improved HIV and chronic disease health and may decrease acute care use and health costs. So first, looking at the first steps of the model, looking at the nutritional pathway, food support programs have been shown to improve food security, diet quality, and can contribute to weight loss or weight gain appropriate to the goals of the program. As an example of this, we conducted a small pilot study with Project Open Hand in San Francisco, which is a free meal distribution program. And actually, they're part of this large food is medicine movement, which is driven by non-governmental organizations across the U.S., trying to get medically tailored meals or medically appropriate meals to be incorporated as part of Medicaid in many settings, and to be reimbursable. So we were approached by Project Open Hand to help them develop this program, and we decided to evaluate it among HIV-infected patients and individuals with diabetes, and so we wanted to do a pilot study of this comprehensive nutrition program. Sorry. Okay. So what we found is that in this pilot study, recipients of this food had a significant decrease in food insecurity, so about 80% were food insecure at the beginning of the study. That decreased to less than 30% at the end of the study. We also saw statistically significant decreases in sugar and fat consumption and statistically significant increases in fruit and vegetable consumption as well as dairy consumption. And other studies in chronically ill populations have also found similar things. In the international context, there's been a number of studies using clinic-based food support that shows that food supplementation can improve weight status, particularly among undernourished individuals. And this was seen in studies in Kenya, Haiti, and Honduras, among others. In terms of the mental health pathway, in our Project Open Hand pilot, we saw a 23% reduction in symptoms of depression among recipients of the meals and a 23% reduction in distress about chronic illness. And other studies in chronically ill populations have also found similar things. Studies show that food support programs can make it easier for people to manage their illness. So in one large multi-city study, it was found that receiving diabetes-appropriate food made it much easier for individuals to self-manage their diabetes and improve their adherence. In our Project Open Hand pilot, we found that while only 47% had excellent ART adherence at the beginning of the study, that increased to 70% at the end of the study. And in a study among HIV-infected individuals in New York City, the recipients of medically appropriate food had a 68% lower odds of missing their appointments. So what are some of the mechanisms for how this food support improved adherence? So in our Project Open Hand population, people really did describe that getting the meals facilitated routine and structure in their life. So one participant says, being provided with the food and having all of it defined, like breakfast, lunch, and dinner, having a routine in that respect and more structure in my daily life incorporated the whole idea of being more compliant with my meds. Very commonly, both in our Project Open Hand study and in many studies internationally, people describe reduced side effects of being able to take their medications with food. So one participant says, towards the end of the month, you don't have any food. You still got to take your medicine. You don't want to do nothing. You just want to stay at home. But I haven't experienced it within the last 4 or 5 months since I've been on here in the pilot program. And people also described that it eased overall physical and mental health concerns, making it easier for them to adhere to doctors' recommendations. So a participant says, I actually made my clinic appointments. I made them. Maybe it's a side effect of having the pilot program and being in a better physical or mental state of mind. So FHI 360 were recently tasked and funded by USAID to do a comprehensive review of economic strengthening programs and HIV clinical outcomes. And as part of that, they reviewed the evidence on food assistance interventions. And this is unpublished, but they said it was okay that I shared the data today. They're going to be publishing it later this year. Out of the 11 studies that looked at food support and adherence and viral suppression, all of those found a positive impact. And out of the 6 studies that looked at retention and care and food support, about half found a positive impact and half found null effects. But I will just point you to the issue of the quality of the studies. Only 4 of these studies were assessed to be of high quality, so there clearly is a need for more research.
Sheri, do you know how they define retention care?
I think they defined, you know what, I don't remember. I will have to look back at that. I think it was based on the previous year, people having seen their doctor for at least in the past 6 months, but I'm not 100% sure. So outside of the context of HIV, diabetes appropriate meals can improve diabetes outcomes. So here are 3 studies, including our Project Open Hand study, where you see improvements in hemoglobin A1C, which is the key metric of blood sugar control in diabetes, among recipients of diabetes appropriate food. At least small pilot studies suggest, and more studies are needed, that food support can improve healthcare utilization. So in our Project Open Hand study, for instance, we saw that participants were 63% less likely to be hospitalized in the 3 months prior to the visit and 36% less likely to visit the ER among those that received the food. And in New York City, although in our pilot this wasn't statistically significant, but we have a larger study underway. And a New York City study found very similar things in a pilot study. Another pilot study in Philadelphia suggests that food support can improve healthcare costs. And in fact, among HIV-infected individuals receiving medically tailored meals in a food organization called MANA in Philadelphia, they found 31% lower monthly healthcare costs. And people do think, well, this seems very costly, particularly providing comprehensive nutrition. How can you recommend doing that? But if you think of the alternative, it's actually quite cost effective. It's estimated that you could feed someone 3 meals a day for half a year for the same cost as spending 1 day in the hospital. And this includes not just the food costs, but also the costs of the personnel. So we've now been able to scale up our food as medicine study, and we've just now recently completed a small randomized control trial with 200 HIV-infected individuals, looking at the impact of this food support on HIV clinical outcomes, the mechanisms, and we'll also be looking at cost effectiveness. So stay tuned for further results. Looking outside of HIV and diabetes, I'm also conducting a study with Rita Wynn at the San Francisco Department of Health, which is a randomized control trial of Zuckerberg San Francisco General Hospital patients hospitalized with congestive heart failure to see if this intensive food support intervention can decrease readmission rates. So based on all of the negative health impacts of food insecurity that I've just reviewed, a lot of organizations are now endorsing regular screening for food insecurity as part of routine clinical care. For example, the American Academy of Pediatrics recently issued a statement to screen all pediatric patients for food insecurity and refer them to services. Kaiser Permanente Colorado is now screening all pregnant women and children for food insecurity. And the AARP Foundation, which serves vulnerable populations over age 50, is doing the same, and they're all referring their food insecure patients to food support services. Similarly, the American Diabetes Association just finally came around in 2016 to recommend screening for food insecurity, and they recommend a one-item screening tool. The question they recommend is, in the past 3 months, did you ever run out of food and you were not able to access more food or have the money to buy more food? And as a victory of the food as medicine movement, first of all, I think they were able to convince the San Francisco Getting to Zero campaign of the importance of food insecurity through the research as well as their advocacy efforts. And so now the San Francisco Getting to Zero campaign has spent about $5 million in the past 2 years towards combating food insecurity as part of their Getting to Zero campaign. And recently, again, as a result of their advocacy, Governor Brown in California has approved a statewide demonstration project as part of Medi-Cal to provide medically appropriate food to chronically ill patients. So hopefully that will lead to some larger scale policy changes. So in the last 10 or 15 minutes, I just wanted to turn to some other approaches beyond food support. So certainly, food supplementation is a very important strategy and may be the only strategy possible in certain settings, particularly in chronically ill, urban poor patients. However, as I've already mentioned, if you're relying on charity or clinics for food, you may find that that's socially unacceptable. You may still have anxiety about your food supply. So it may not be addressing all components of food insecurity. And while cost effective, it still is maybe costly to scale up, certainly in certain resource-poor settings. So UNAIDS has been advocating these longer-term social protection approaches, like livelihood approaches, which may be better able to address all of the pathways through which food insecurity negatively impacts health. But when we think about engaging these more complicated livelihood approaches, you really need true transdisciplinary partnerships. So moving beyond your traditional partnership with the health sector and NGO, and bringing in new partners like agriculture, finance, policy partners, and others. And so we tested one such approach in Kenya, along with my colleagues Craig Cohen and Elizabeth Bakusi at the Kenyan Medical Research Institute. The trial was called Shamba Maisha, which means farming for life in Kiswahili. And the goal here was to target the root causes of food insecurity and poverty in the region, which in this case was increasing drought and inconsistent rainfall, which have been worsening in the setting of climate change. We tested this in 2 clusters of 140 people. The intervention had 3 components: a microfinance loan to purchase a human-powered water pump, as well as farming implements like fertilizer and seed, the water pump itself, and then training in sustainable agricultural practices and financial management. So going back to the framework, we had hypothesized that this multi-sectoral intervention would improve food security and household wealth, and then through the various pathways I've already reviewed, as well as through enhanced empowerment, would lead to decreased HIV morbidity and mortality. So here are the results of our pilot data. You'll notice that the intervention group is shown in the blue circles and the control group in the red X's. You could see at baseline there were very high and similar levels of food insecurity in both groups. And by 6 months, we already saw statistically significant reductions in food insecurity in the intervention group compared to the control group that persisted throughout the rest of the trial. We weren't powered specifically to look at HIV clinical outcomes, and you can see, in fact, quite a discrepancy at baseline, attesting to the need for a larger randomized control trial. So you can see more control patients were actually suppressed at baseline. By 6 months, those trends had reversed, and the statistically significant improvements in viral suppression persisted throughout the rest of the study. And this was actually the first study, to our knowledge, to link an agricultural intervention to hard clinical endpoints. We saw parallel increases in CD4 cell count in the intervention compared to the control group. And finally, for a measure of empowerment, we also saw statistically significant improvements in self-confidence. So getting to our qualitative data, participants indeed did describe changes in health along all 3 mechanisms. Along the nutritional pathway, a participant says, I think I've put on some weight since it started because I have been eating better. In fact, the other day, a woman was telling me, nowadays my face looks healthy and so on. And it's only me who knows the secret to it. It's because I am surrounded by vegetables. Along the mental health pathway, and this was very common that people actually described a change in their level of hope. It has given me hope and will to do my things, not like before when I used to be hopeless and scared. I also have the will to go about my duties and farm, from which I get food and money, thus living like any other person. And along the behavioral pathway, a participant says, I find getting to the clinic to be a little easier because now I'm able to get money for my fare to the clinic when my time to go to the clinic comes. I get the money from the farm produce. Beyond the HIV treatment outcomes, when you're talking about an intervention like addressing food insecurity, one of the things I really like about it and that drew me to it is it really moves you beyond the sort of thinking about vertical disease categories. Because food insecurity is addressing a root cause that could have multiple effects on different health outcomes. And so one of the effects that we saw was dramatic changes actually in HIV stigma. So people in the community, our participants would say at the baseline they were viewed as lifeless, as worthless. Like literally they would say that we were a waste of life in the community. And then what ended up happening is, first of all, they got healthier. They were productive, and not only were they productive, but they were more productive than their neighbors. So the neighbors would then come to them and ask them for advice, and it would change their status. And I'll just read the second quote here. Since I joined Shamba Maisha, I've experienced a big change, and now I have a name. Nowadays, when I hear anyone who wants to purchase vegetables, I just urge them to come to my home, and they will get them. They now view us as people. And in case of any problem and the village committee asks for contributions, I make mine immediately. This makes them realize that I am powerful and that I'm also a human being. There were also changes in gender empowerment in the household, and people did describe improvements in decision making. And I'll just read the first quote here from a male. Since I joined Shamba Maisha, we all have an equal say when it comes to our property, be it on selling a cow, selling some farm produce, harvesting crops from the farm. Everyone has an equal share in the resources. My 2 wives and I have to give their opinion before we see which opinion to adopt. The chair to our meetings is not necessarily me. It can be any of the 3 of us. And remarkably, people even described a reduction in violence. And this is a quote from a male. He says, I used to be violent. The violence would mostly relate to money issues, and this is the root cause in many homes. But right now, she manages the farm and takes it as hers. Now she has some very few coins in the pocket, and if I need some money, I can always ask her. So it is taking care of some form of domestic violence to some very big extent. And we're now in the 3rd year of scaling up this trial into a large randomized control trial. We have an adult study that's the study that Craig and I are the PIs with Elizabeth Bakusi as the Kemry PI that's looking at HIV clinical outcomes. Lisa Butler has a paired study, R01 study, looking at the outcomes of growth, development, and nutrition in the children in the household. And in fact, her pilot study did show improvements in height and weight for Z-scores in the pediatric population. And Sarah Young also has a study looking at water insecurity and changes in water insecurity in this intervention. We just got a good score, very good score, so we hope it's funded on an R21 to look at adolescent sexual and reproductive health at N-line. So looking at the impact of this household-level intervention on adolescent sexual and reproductive health, and we're hypothesizing both adolescent-specific pathways and caregiver pathways that could lead to improvements in these outcomes. So just for the last few minutes, I'm going to get a little more experimental here and talk about something that has been a strong interest of mine, which is when I have spent time in Kenya speaking to farmers, it was just been amazed at how everybody just, as a matter of fact, will say, well, what's driving the food insecurity? They're like, oh, it's climate change. You know, the most uneducated farmers, unlike our politicians that have really had no schooling, will just be like, of course, because of climate change, we have a lot of drought here. And so in realizing how much food insecurity was driving, how much climate change was driving food insecurity in Kenya and other regions, we also noted that Shamba Maisha happens to be an intervention that is adaptive to these type of changes brought upon by climate change. So it helps people irrigate their farms year-round in the increasingly long dry seasons. And they're also practicing a form of agriculture called regenerative agriculture that's repleting the soil of nutrients because they're diversifying their crops, and it's increasing the diversity of the soil microbiome. So I'll just take a minute to talk about all of the ways that climate change can negatively impact food insecurity. And this is just looking specifically at food availability. And I think this is just important for anyone who's interested in food insecurity interventions to consider, you know, because this is such an important driver. So the increasing frequency of droughts can lead to large-scale crop losses. Rising temperatures reduce crop yields by both decreasing photosynthesis and reducing soil moisture. Heavy rains and storms, flood fields, erode soils, and wash away crops. Melting glaciers and changing rivers will reduce the water that's available for irrigation and already has. Higher levels of ozone actually directly damage crops. You see rising sea levels flood and salinize crops. In the higher temperatures, plant and pest diseases will thrive more readily, and you see more animal deaths and migration of fish in the setting of higher temperatures. There's also food safety concerns and more bacterial replication during food transport. So lots of different mechanisms. And similar, going back to these maps that I've showed you earlier, those very same regions that have the higher prevalence of food insecurity, HIV/AIDS, and gender inequality are those regions that are most vulnerable to the impacts of climate change. And then taking it beyond food insecurity, there's actually mounting evidence that global environmental change can be perpetuating the HIV/AIDS epidemic. And I'll just spend a minute or two on this slide. So all of the, and this is a conceptual framework that my colleague Peter Chin Hong and I developed to try to understand the link between environmental change and HIV/AIDS. So rising temperatures, sea levels, flooding, drought, deforestation, all of these other changes can contribute to through a number of pathways to worse HIV/AIDS acquisition and morbidity and mortality. I've already talked about food insecurity as a key mechanism. These changes also drive increased migration, which we know to be critically important for both HIV acquisition risk as well as health outcomes among people infected. These changes also bring about higher prevalence of diseases like malaria and diarrheal disease that worsen morbidity among HIV-infected patients. And then, of course, natural disasters that are occurring more and more frequently erode public health infrastructure, making it more difficult for people to be treated with HIV. At the bottom, you can see that HIV/AIDS and associated morbidity will be contributing to multi-disease burden, decreased household resources, and decreased labor availability. This will then feed back both to worsen food insecurity, and then food insecure individuals that don't have a lot of food will end up further depleting natural resources, which then leads to this perpetual cycle. So what kinds of interventions, in addition to the one I showed you, we think about that would be potentially environmentally sustainable? And there's been a growing interest in this country and elsewhere in urban and community gardens as an intervention. And early literature suggests that urban gardens can increase physical activity, could increase fruit and vegetable intake, may improve social capital and community pride, and could improve access to culturally appropriate foods, although not a lot of studies have looked specifically at health impacts. So we did do a small qualitative study with a Latino-led urban garden organization in San Jose called Verde, where they provide raised garden beds to urban poor individuals, and then provide some training as well as some nutrition education of how to utilize the vegetables. And in our 45-person qualitative study among HIV infected individuals, they had one complex that was HIV infected, and then they also served largely overweight individuals at risk for diabetes or prediabetes. We found that the intervention improved diet, led to more exercise, reduced their stress and mental health, led to weight control, and improved management of their chronic diseases. And I promise this is the last qualitative slide. I will show you along these pathways so not to overdo it. But along the nutritional pathway, a participant says, my family has lost weight. We're cooking new things, losing weight, feeling healthier. We got blood pressures down. My oldest daughter was at risk for childhood diabetes. That's gone. Along the mental health pathway, a participant says, having the garden has gotten me through some pretty tough times. There were times that were very stressful for me, and it's like therapy. I got out there and I just garden and I plant. I find it very therapeutic, and I'm really grateful that I have 2 plots. And finally, on the behavioral pathway, in addition to adherence, people actually described a new pathway of health behavior pathway of doing more exercise. So a participant says, we do more exercise because before we would just finish dinner and sit down and watch TV, and now we don't. Now we go outside and cut the grass, clean up the garden, so when we come back in, we're already tired. We have to prepare the soil, pull weeds, dig, and when we finish, we're sweating. So in summary, we've seen that food insecurity and poor health interact in a vicious cycle, that food insecurity interventions can reverse the cycle and multiply and sustain the benefits. We've also seen that improving food insecurity can address multiple health problems simultaneously, and I urge you all to consider environmentally sustainable approaches where possible. The implications of all of this work is that addressing fundamental human rights, such as access to food, should be an integral component of health programs serving impoverished populations domestically and worldwide. And I will just end with my acknowledgments. Too many great collaborators to list. I wanted to acknowledge my project coordinator, Lila Shira, and Tessa Naples for helping with some of these slides. And I list my funders. Most of my studies have been NIH funded, but I list the other sources of some of the pilot studies as well. Thank you.
That was great. Yeah.
Questions. Number one, do you think that the tax reform has been influenced by your data? California will be punished for the kind of things that is introduced financially, and the question is whether money will be available to the extent that it has been. Number two, more seriously, I think especially in developing countries, given the spreading droughts in the Near East, in Southern Asia, in Africa, water insecurity needs to be assessed in addition.
Yes.
And my major concern is, in addition, that this is likely to add to the overpopulation that is already happening in those countries, because now they're healthier, they will have more kids, and the kids will survive better. So doesn't it have to be connected also to some form of reproduction control?
And I will say there's some really interesting programs like this OASIS program in West Africa that is doing a lot of this intersection between climate change and sustainability work as well as population and reproductive health. So women's empowerment. In some of the programs that are being developed, women's empowerment is a key component of that, because to address climate change issues, you also have to improve women's empowerment to decrease the fertility rate. And that, I think, is a very important part. I was saying that we also wanted to look at our Shamba Maisha intervention among pregnant women as well, to see if this could improve birth outcomes and if it also could improve sort of reproductive health decisions as well.
Thank you very much. Very interesting and important talk. I just wondered whether your team is making any effort to get some of these data into some of the organizations which can change the world, like the UN or the World Bank, or because it is so obvious and so convincing the data that it may really influence larger policies.
thank you very much for that. And I think that we have been, over the years, I've had a very close contact with the World Food Program, who has been advocating and using these data. And I think some of our data has influenced them to provide food supplementation to HIV programs in different places. I think that as academics, when I worked with Project Open Hand, who is a food distribution organization, it really struck me how much more effective they are at translating work into policy. So that small pilot study that I showed you, which the data is, poor quality compared to some of these other much larger studies, they have effectively, then because of that study, and their advocacy, we got to DC to give congressional hearings and Senate hearings, and then they were the ones who used that data to advocate for the statewide Medi-Cal demonstration project. So I think there is a lot more work to be done, and in fact, we are thinking in our group about how to effectively to do this more effectively, learning from our community partners that are clearly doing a much better job at that. So.
I have a personal comment and then a question.
Sure.
Actually, this was really fantastic and a really great example of bringing together people from multiple disciplines. So the personal part about this is that my husband, who's an architect and urban designer, was part of a project over the past 7 years, started by a figure skater who's a surgeon around finding cures for childhood obesity. And they came to many of the same places as you and looking at many of the same constructs around, more focused on the Northeast Coast and New York and how food comes in and out and systems around that. And he's writing a book, and it would be really great if I could put him in touch with you, because some of your work would be really helpful for them, and I don't think they've actually seen this health perspective that you have here.
Sure.
So that's the personal request. So the second question has to do with mental health, because you focused on depression. So I guess one question is about, did you look at other mental health problems, which I could see actually playing out that might be related to stigma and some of the other things. But I also thought of you, Andrea, and issues around inflammation and joint root causes.
Yeah, absolutely. So, I mean, mental health, I will say that from a personal perspective, I started as a neuroscience major and almost went into psychiatry a few times, but then, so I've always been driven by an interest in mental health and this sort of intersection with health behaviors. I know. My husband did go into psychiatry. I talked it up. We were both in internal medicine. I talked up how great psychiatry was. He's like, okay, I'm going to switch. So he switched residencies, but I stayed here with a strong interest in mental health. So I will say that, yes, I mean, so I think that a whole bunch of things come up. So I think I mentioned already that PTSD has been associated and anxiety disorders. I think that there is also a very strong link, as I mentioned, via the stigma pathway. There's a lot of shame that people have. And actually in San Francisco, where I would say HIV stigma, at least in the Tenderloin, in other neighborhoods where it's predominantly African American and Bayview Hunters Point, there's a ton of stigma. But in the Tenderloin, there is not a lot of HIV stigma, but there is a lot of stigma around accessing free meal services. And so people really, it does just bring up this sort of fundamental feeling of I have failed because I can't even meet my basic needs. And so I would say even clinically, I deal with that a lot with patients. So I think it is, other than depression and anxiety, it just, I think just overall worsens people's, view of themselves, even if they don't meet criteria for a disorder. So I do think it's very critical. And it's just always that constant stress about where your food is going to come from that, can drive some of these pathways. And getting to the inflammation pathway, I do think that very well could be a pathway. I showed you, we have stress data in the WIHS cohort. We've collected hair cortisol as an important pathway in one of our studies that led by Janet Turan on HIV stigma, but it unfortunately doesn't overlap with the participants for whom we have this inflammatory data. So we won't be able to look at that as a pathway, but I do think that's an important pathway. I will mention that when we're trying to understand how food insecurity is affecting inflammation, the literature had suggested that high-fat diets and that being overweight would be an important mechanism. When we looked at those as mechanisms, we didn't see that playing out, but it is probably just that our diet measure didn't adequately capture people's fat intake, and our body mass index does not adequately capture fat stores. So I think we're just unable to assess for that mechanism.
Christine, Andrea, but I'm going to jump in just on the mental health piece. Sort of, if you can comment on cause effect, or to use the food analogy, chicken and egg.
Yes, yes.
Because, I mean, one can hypothesize that people with mental health problems are more vulnerable to becoming food insecure. That whole thing.
I think that this is the case with pretty much so many of the outcomes. Maybe not the chronic disease outcomes as obviously, but with HIV-infected people, once they're sick, will become more food insecure. So it is sort of a vicious cycle, and the same thing happens with mental health. I think that they both are playing out. So mentally ill individuals are less able, to care for themselves, and so clearly that would contribute to more food insecurity. But in our qualitative data, people really do describe that pathway very strongly about food insecurity just driving so much stress, making them feel hopeless, worsening their depression. So I think it really does definitely go at least in that way as well. And I think the same thing goes for substance abuse. So the common thought is that people who are substance abusers will become food insecure because they're spending their money on drugs instead of food. But in fact, what we're finding both qualitatively and then at least looking at using our quantitative data as best as we can to look at that is that food insecurity is a driving substance use as a coping mechanism to deal with everything that brings up for people with being food insecure.
Hi, I'm Chrissy Ryle. I'm a fellow here at the HIV Center, but prior to being here, I came from the University of Colorado, and this is a big piece of what we do. And I worked on a neighborhood-level intervention that was not for HIV-positive people. It took place in a food desert, the Park Hill neighborhood. And it was really aimed at getting local residents in this food desert to use community gardens that we set up, and we call them pocket parks, which are green spaces that are for people to use to exercise and relax. And we had a lot of trouble getting community buy-in from the residents of the food desert that we set this intervention up in, but a lot of interest from people in adjacent, more affluent communities in using these services. And it seems like you just did a great job getting community buy-in for what you did, and I'm interested in what you did.
So, I mean, I will say that for, it's interesting because when we started doing urban gardens, we had, I had some students actually who went to work on Shamba Maisha, and they were very excited. And we had always joked about how are we going to do the domestic Shamba Maisha. And one of these students was involved in an urban garden organization in the Bay Area. And we started working with them as a first, early pilot study led by one of our master's students. But it was one of those situations where it was the students were actually volunteering in the garden, and they were giving the produce to so it wasn't that there wasn't buy-in, but the people that we wanted to benefit from the gardening weren't doing the gardening. So we actually were like, well, it's going to be very difficult to assess health impacts because it's so diffuse. People may get some vegetables from this community effort. So then we looked for this organization that was doing individual gardens where we would be sure that the people doing the gardening were the ones benefiting from it. And I will say that we had nothing to do with community buy-in. This is that organization, which is a Latino-run organization in San Jose that has really, really been a big part of the community. And so we just submitted an R01 application. And again, speaking to how great they are at advocacy, it was definitely the first R01 application I submitted where we had a Congress letter of support because they were so connected that they were like, oh yeah, sure, we can get our local Congress people to support this. It was like great. So we'll hope that helps our application. But yeah, so I think that they were responsible.
Hi, very interesting. I really, especially, my interest is primarily in inflammation and stress, so it was great. And actually, I have two questions. First, I want to know if you considered assessing the consumption of omega-3.
The consumption of what?
Omega-3.
Oh, omega-3, yes, yes.
So because I think that there is a strong association, if you have the, USS, the amount or, estimated amount of omega-3 that they consider that they need.
You're talking about to decrease inflammation.
Yeah. So if there is an because in your table, the regression, I guess it was the analysis with the two inflammatory biomarkers. I noticed that it was not BMI.
The reason that it's not in there is because we looked at it as a potential mediator. So we actually, in our paper that is about to be submitted, we sort of showed first the models without the mediators, and then we added body mass index as well as fat intake to the models, which were both associated with inflammation, but did not mediate the effects of food insecurity. But I think it is because we're not adequately getting at those concepts with those measures.
And I also would like to know I noticed that there is a difference in the TNF-alpha by race.
Yes, and that was very interesting. We are thinking about that because they're definitely, I should go back to it, but that was a striking finding that I don't think is explained in the literature. So let me just pull that back. Have you heard of that or
seen it? Yes, actually, I recently submitted a case.
Oh.
And it's kind of related to that.
Interesting.
It seems like there is some literature about genetic.
Sorry about this. I have a lot of slides. Oh, there we go.
Yeah.
There we go.
That was really interesting.
Yeah. And we also saw, both Latino and African Americans had lower, right, or had higher inflammation.
Yeah, that's really interesting.
Yeah.
Because apparently there could be something related to type of food or the quality of food.
Yeah.
But also there should be some genetic difference. That's as far as I know.
And it could also be maybe more stress or stress pathways that could be contributing to it too.
I have two people waiting, and we have just a couple minutes left. I have Nadia and Teo.
I just have two quick questions. In terms of the food, the food programs, I feel like you described a lot of different options. So some you deliver the food to them directly, some are community gardens. And I was curious how much you think the delivery mechanism matters. So for example, if you're delivering the food to them, the food's already prepared, they don't have to spend time doing that. There's also the social component, maybe someone who's in the house, you do the garden, there's like an exercise component. So I was curious, did you target that to specific populations, or is it kind of
Yes, very much so. So Project Open Hand, we actually, in our pilot study, we had initially excluded people that were relying only on the home-delivered meals, just mainly because Project Open Hand couldn't manage it. But then in the larger randomized control trial, we included those people because we think that those people, their only way of getting food, they're too sick to get it other ways. And so this may be a population that you really can potentially, for instance, prevent readmissions and other things by getting the home-delivered meals. Whereas I think, the more able and fit you are, the more these other interventions, would make a lot of sense. So for instance, for elderly populations, urban gardens that are not fit, urban gardens may be a challenging intervention, but for younger individuals at risk of diabetes and prediabetes, or any chronic disease or childhood obesity or all of those other things, I think urban gardens would be a really good approach. The other thing is just when you're talking about, I'm very interested in the livelihood approach, but we don't really have the similar kind of easy mechanism to roll out in a domestic context. My husband actually, who I mentioned is a psychiatrist, did a vocational training program intervention among vets to decrease PTSD. And so I think maybe more research in that area would be interesting.
You hold it because you'll be seeing her later, right? Yeah. Teo.
Wonderful presentation. Thank you. What's a little bit unusual probably for us is that you spoke about food insecurity as an independent variable in most of your slides. And I think there was one slide where you had the causes, and it was social and structural.
Yeah.
In your answer, you said a little bit about psychosocial mechanisms. Have you more thoughts about what it is and what its causes
Yeah. So you're saying does the causes of food insecurity and whether that affects the intervention? I mean, I think very much so in the sense that if, for instance, like if the main issue is having poor access to high-quality foods, like food deserts, then that would lead to one type of intervention versus it just being an income-driven issue. That would lead to a different type of intervention versus a climate change-related cause. So I think the things that are driving food insecurity are very important. And actually, in my K-24 mentoring grant that I mentioned, one of our aims is using geocoding data in the U.S. to look at the neighborhood level drivers of food insecurity in the different regions to help us better target interventions. Because I assume that there are we've already seen quite big differences between the sites that are, the original WIHS sites that were more northern sites and then the new southern sites that were added in WIHS, where the prevalence of food insecurity and the drivers are quite different there. So I think it will be interesting to see. But I completely agree that we have to take that into account in thinking about the interventions.
Okay, we're actually over time. I know some other people have time with you after this. That was really fantastic. Thank you so much. That was fantastic.
Oh, thank you.
I'm going to have lunch with you, so I'll talk with you more.
Yes,
See you a couple
thank
of times.
you. Okay, no.
But, yeah.